state coordinator of PG teaching, who was instrumental in raising the standards of the PG program. I would like to welcome Anandakesavan sir, scientific coordinator of this PG teaching. It's beyond doubt that this program has been successfully running with high standards in all over the country. I would also like to welcome the zonal coordinator, who is very prompt, Dr. Ledika, whenever asked for help. And I would also like to welcome Sringara Velu sir and other dignitaries who have joined, our senior pediatricians, Purushothaman sir, and teachers who have come online. And we are proud to have our own mentor from Kochi and the legend in newborn hearing screen from the country, Dr. Abraham K. Paul, for his talk today. And especially, I welcome you, sir. He is Executive Director of his Dream Project Child Care Center, which is celebrating the 30th anniversary this year. And sir is a senior pediatrician in Indira Gandhi Cooperative Hospital. I would like to welcome the second speaker, Dr. Megha Krishnan, pediatric ENT specialist, Lisi Hospital, Kochi. And our PGs are all eagerly waiting for your OSCE questions. Last but not the least, welcoming all our participants, seniors, and teachers who have found time to come online today, this Thursday evening. Thank you. Dr. Rias is muted.
Rias muted I. Rias muted I.
Okay. Thank you, Dr. Abi. Respected past Vice President Dr. Sringara Velu sir, the past President of IAP Kerala, Dr. Joseph, respected seniors, the faculty for today, the guest of today's program. The guests for today's program are Abraham Paul sir, as well as Dr. Megha, and Mohandas sir in absentia, and Dr. Ledika, the PG program coordinator. So today's session is special in a sense that we were having lectures from the pioneers in various fields. And today we have our own faculty, Abraham Paul sir, who had actually popularized newborn screening in different parts of the country. And he was the one who was instrumental in making Kerala a hearing-friendly state. And he is going to speak to us on this month, on which the National Hearing Day also falls. And we also have another speaker, a specialist from pediatric ENT. And we know that for DNB exams and all, we get a lot many questions regarding audiogram, all those things. So we need our students to familiarize with that. So she had agreed to give some questions on pediatric ENT question. So I thank both the faculty for agreeing for the program. And I'm very grateful to the Cochin branch, because like we told, it is out of turn because of the Bogala festival. Trivandrum team was not free this week, so they took up the challenge. And I also thank all the leaders who have joined and the senior teachers who meticulously attend this program and make this program. I wish all the best to the program. Thank you. Maybe I think we will, Dr. Vipin is away. I think he is not here. So we will directly ask Dr. Latika, the coordinator of the zonal coordinator of the program, to introduce the speaker and start with the teaching program.
Thank you, Dr. Riaz. Good evening, all. Good evening, all. So today, just recently we observed the National Hearing Day on March 3rd. So today's program is very special, as Dr. Riaz already mentioned. We have the father of newborn hearing screening, none other than Dr. Abraham K. Paul, who doesn't need any introduction to anyone in this group. And I'm very honored to invite such an eminent speaker on this special day. Sir will be speaking on early detection of hearing loss in children, which is relevant to all of us. And the second part of the academy program is an OSCE on pediatric ENT topics conducted by Dr. Megha Krishnan, who is a pediatric ENT specialist at Lisi Hospital, Kochi. And Madam will be asking questions, and we have arranged PG students for answering these questions. So Madam can call one of the PG student who will be answering. The others can answer in the chat box. So I think we can straight away go to the program. And I'm honored to welcome Abraham K. Paul, sir, to this platform to deliver his talk on early detection of hearing loss in children. Good evening, sir. Sir, the screen.
Sir is muted.
Sir muted ആണ് sir.
Sir muted ആണ്. Abraham sir muted ആണ്. Muted ആണ്.
Sir ഒന്ന് unmute ചെയ്യാൻ try ചെയ്ത് നോക്കൂ sir.
എബി എന്ന് അൺമ്യൂട്ട് ചെയ്ത് കൊടുക്ക്. എബിക്ക് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റത്തില്ലേ? എബിക്ക് പറ്റണമല്ല. എബി അല്ലേ ഹോസ്റ്റ്?
അല്ല.
ഹോസ്റ്റ് ആരാണ്?
ഇപ്പൊ ചെയ്യാം സർ. ചെയ്യാം.
സാറ് അൺമ്യൂട്ട് ചെയ്ത് സംസാരിച്ചാൽ മതി സാറേ.
മതി.
സാർ നേരത്തെ സംസാരിച്ചായിരുന്നല്ലോ.
സാറിന് അൺമ്യൂട്ട് ചെയ്യാമല്ലോ എബ്രഹാം സാറിന്.
എബ്രഹാം സാർ താഴെയാണ് സാറേ. താഴെ 7 താഴെ. സാറിന്റെ വീഡിയോയുടെ തൊട്ടപ്പുറത്തൊരു ഐക്കണില്ലേ സാറേ? അത് നോക്കൂ. ഈ വീഡിയോയുടെ അപ്പുറത്തൊരു ഐക്കൺ ഉണ്ടല്ലോ.
ഓഡിയോ
ലോവർ പാർട്ട്. താഴെ ലോവർ പാർട്ട്.
ഓഡിയോ കാണുന്നത്
ലോവർ പാർട്ടില് ലെഫ്റ്റ് സൈഡില്. ലെഫ്റ്റ് സൈഡ്. അവിടെ. ഗോപിക്ക് പറ്റുന്നില്ലേ അൺമ്യൂട്ട് ചെയ്യാനായിട്ട്?
അല്ല സാറേ, നമുക്ക് ഹോസ്റ്റിനും കോ ഹോസ്റ്റിനും
മറ്റേ ഹോസ്റ്റിന്റെ അടുത്ത് പറഞ്ഞു അത് ആസ്ക് അൺമ്യൂട്ടിനെ
അൺമ്യൂട്ടേ പറ്റത്തുള്ളൂ. സോ ദി
പറ്റത്തുള്ളൂ സർ.
നമ്മൾ
ചെയ്യാൻ പറ്റും. സാറിനൊന്ന് വിളിക്കാവോ?
ഞാൻ വിളിക്കുന്നുണ്ട് സാറിന്, പക്ഷെ ഫോൺ അടുത്തില്ലേ എന്തോ സാർ എടുക്കുന്നില്ല.
സാറേ സ്ക്രീനിലൊന്ന് ടച്ച് ചെയ്യേണ്ടി വരും, അപ്പോഴേ മ്യൂട്ട് ആ മൈക്ക് സിമ്പിൾ കാണുള്ളൂ.
So if sir is having a difficulty, can we flip the program? Like, shall we start with the OSCE and then we go on to the lecture?
പ്രിയ സാറിനെ വിളിച്ചു കിട്ടിയോ?
എനിക്ക് കിട്ടുന്നില്ല, അതാ ഫോണിൽ ഞാൻ വിളിച്ചിട്ട് ഒന്ന് ചോദിക്കട്ടെ, അങ്ങനെ ചെയ്യാലോ?
ശ്രദ്ധിക്കുക, ലോട്ടറി അടിച്ചു ഇൻസ്റ്റന്റ് റിയൽ
റിയാസെ, ഞാൻ സാറിന് ഫോട്ടോ എടുത്തോട്ട് അയച്ചിട്ടുണ്ട്. എന്താ ചെയ്യേണ്ടതെന്നുള്ളത് സാറിന് ഫോട്ടോ എടുത്ത് അയച്ചിട്ടുണ്ട്. അയക്കാൻ സാറ് വാട്സാപ്പിൽ നോക്കിയാൽ മനസ്സിലാവും. ഞാൻ വാട്സാപ്പിൽ
ഇപ്പം ഹെൽപ്പ് ചെയ്യാൻ ആള് ചെല്ലുമെന്ന് പറഞ്ഞു വീട്ടില്.
അല്ല, ഇബ്രാഹിം സാർ ആ വാട്സാപ്പ് തുറന്നു നോക്കിയാൽ മതി, ഞാൻ അയച്ചിട്ടുണ്ട്.
ഞാൻ പറഞ്ഞിട്ടുണ്ട് സാറേ, സാർ ഒന്ന് ലീവ് ചെയ്തിട്ട് കയറട്ടെ, അപ്പൊ ചിലപ്പോ ശരിയാവും.
ഞാൻ വാട്സാപ്പ് ഇട്ട് കൊടുത്തു കൊടുത്തിട്ടുണ്ട് സാറിന്. ശരിയായി.
ഓക്കെ ഓക്കെ.
കേൾക്കുന്നുണ്ടോ? അപ്പൊ
കേൾക്കാം സാർ, കേൾക്കാം, കാണാം, കുഴപ്പമില്ല. ഓക്കെ.
So as you know, we had the World Hearing Day on 3rd of March, and this actually is reminding us of a responsibility to see to it that all the babies born in a hospital, all who are in our care, are screened for hearing loss before they leave the hospital. And another important thing is that whenever a child is brought to us, the first question we should ask is whether a child is speaking or not, if the child is after the age of 1 year. So because language development occurs only the hearing is proper. So as you know, out of the 5 senses of touch, smell, hearing, vision, hearing actually is the most important. And because if there is hearing impairment, it is one of the most devastating sensory impairment with significant social and psychological implications. And if there is a hearing loss, it should be detected at the earliest so that the child will develop a near normal speech and language. So actually, I am reminded of this child, Karan Peter, whom I saw at the age of 2.5 years. It was actually in 2002. And he was admitted for a pneumonia, and I was curious to see his hearing aid in this small child and asked the mother about the details about this. So in fact, she was very angry when I asked her, because she said that she suspected a hearing problem in this child when the baby was about 5 to 6 months old. And she told the pediatrician the child got a problem, and the pediatrician made fun of her. And subsequently, she got the baby tested for hearing loss at Trivandrum, and she was confirmed hearing loss. Again, she got retested in Chennai, and the child had a hearing aid at the age of 6 months, and he was talking almost normally when this child had 2.5 years. So at that time, I had an idea, why don't we start this program in Kerala or in Cochin? And this was actually the stimulating factor which landed up in having our screening program in January 2023 in Cochin. And this is Helen Keller, who became deaf and mute at the age of 1.5 years following acute CNS infection. And she went through the agony of both being deaf and blind. And she, in her book, wrote, after a lifetime in silence and darkness, that to be deaf is a greater affliction than to be blind, and hearing is a soul of knowledge and information of a high order. And to be cut off from hearing is to be isolated indeed. These are the words of Helen Keller. And this actually is a graph or the audiogram. Here you can see a yellow shade here. Actually, this is when we have a normal speech that is between 30 to 50 decibels. And most of our speech occurs between this area. That is the yellow color you see. And this is spotted and we get a shape of a banana. This is actually the frequency and intensities of the normal speech in our day-to-day life. And when we go for the signs of hearing loss in babies, one of the symptoms are that the baby does not startle at loud noises, does not turn to the source of sound after months of age, and does not say single words such as dada, mama by 1 year of age, and turns ahead when he or she sees you, but not if you only call out of his name or the name, and seem to hear some sounds but not others. These are probably the things when you should suspect a hearing loss in the babies. But whereas in children, when there's a speech delay, you should suspect hearing loss. Whenever there's a speech delay, you should do the hearing test first. Then only you can reassure the parents that your child is all right. But without doing a hearing screening, you can never say or reassure the parent that she will start speaking later. And even there's an unclear speech, if it does not follow directions and just tunes the TV volume too high, always you suspect a hearing loss in older children. And this actually is a section of the outer ear, then middle ear, inner ear, and the cochlea. And the cause of hearing loss can be in the external ear canal, can be congenital atresia, wax, foreign body, trauma, external otitis, stenosis. In the middle ear, otitis media, tympanic membrane perforation, congenital defects and trauma. And the most important is sensory or sensory neural malformations, hereditary or familial, intrauterine infections, the torch group of infections, ototoxic drugs like aminoglycosides in combination with diuretics, NICU graduates, infections, head injury, and noise. And the neural can be problems in the cochlear nerve, auditory pathway, or the cortex, in the cerebral cortex. So actually, we are more concerned about the cochlear or the sensory neural part of the hearing loss. And the type of hearing loss, the conductive, sensory neural, retrocochlear, and central, that is the cerebral cortex. But we are more concerned about sensory neural, that is the cochlear or the neural or the eighth nerve. So the incidence of congenital hearing loss is in the well baby nursery or the general population, it is 1 in 1,000, whereas in NICU, it is 10 times that of the general population, that is 1 in 100. In general population, it is about 3 to 6 per 1,000. These are the incidence of hearing loss. And the critical period of remediation, identification and remediation is before 6 months of age, as per the study or the many studies, that if you do the remediation before 6 months of age, the baby will have a near normal speech and language development, provided it is not a profound deafness. So this is a very important slide. The vocabulary of a child at the age of 3 years is around around 500 to 900 words. But if there is a hearing loss, and if you do the remediation at the age of 2 years, the vocabulary will be around 50 words at the age of 3 years. And in a hearing loss child, if you do the remediation by 6 months, after 6 months, the vocabulary at the age of 6 months will be about 150 to 300 words. And if you do the remediation at birth, the vocabulary at the age of 3 years will be around 300 to 700 words. Actually, this is what we are going to achieve by early intervention, early identification and remediation of hearing loss. And these are the high risk factors for hearing loss. family history of hereditary childhood sensory neural hearing impairment, inherited infections like torch group of infections, craniofacial anomalies, birth weight less than 1,500 grams, jaundice requiring exchange transfusion, and orthodox medications used in multiple courses or in combination with loop diuretics, meningitis, birth asphyxia, ventilation for 5 days or longer, and stigmata of other findings associated with a syndrome. So these are the 10 high-risk factors where the incidence of hearing loss is 1%. And these are certain syndromes. I think the PGs will be more interested in the syndromes. So this is a Treacher-Collins syndrome, Alpert syndrome, Waardenburg syndrome, Pendred syndrome, Crusen's, Gaussian's imperfecta, achondroplasia, Lawrence-Moon, Beadle, achondroplasia, periorbital syndrome, Stickler syndrome, Hurler syndrome, Usher syndrome, Javel-Lange-Naisset syndrome, and Alport syndrome. So whenever you find or identify any of these syndromes, always have the baby tested for hearing loss, because hearing loss is associated with these syndromes. And where actually does the damage to the cochlea occurs? So here you can see the normal cochlea. Here you can see the 3 rows of outer hair cells of the cochlea, and these are the inner hair cells of the cochlea. We are more concerned about the outer hair cells of the cochlea because this is the most important for hearing. And here you can see a normal 3 layers of cochlea, outer hair cells you can see. Where you can see the damaged cochlea, you can see the absent outer hair cells of the cochlea, or in short, this is a damaged cochlea. And the first year of life actually is the most critical period for speech and language development, because the 100 billion neurons form 50 trillion connections by the age of 1 year. And this is actually the critical period of synaptic connections. So here you can see a normal axon and the dendrites you can see here. This again, you can see the axons and dendrons or the neural connections at birth. You can see 1 month, at 4 months, and at 1-2 years. You can see here the complex connections you can see. So this can happen only if the baby is hearing normally. The connections will become firm and complex only if the neurons are stimulated. So this again, if there is a lack of auditory stimulation, these axons and dendrites can undergo retrograde degeneration. You can see here, this is a normal one. This is a axons and dendrites undergoing retrograde degeneration. So neonatal screening, before the advent of neonatal screening, the hearing loss used to be detected between 1.5 to 3 years of age. And by neonatal screening, we can detect the hearing loss at birth, and we can do the remediation before 6 months of age. By universal screening, we mean all the babies born in a hospital or in a city or a district or state are here screened. By target or high risk mean we screen only the high risk babies. And this early identification is nothing very new as far as we are concerned, because even our grandparents used to do the hearing screening, because they used to make the noise from the tumbler and a spoon and see whether the baby looks to the sound. So this was the convention before, and this actually is a modified form developed by David Kemp for newborn, for the see whether the baby is hearing or not. And this person, David Kemp, the inventor of OE technology, 1977 to 98, he took about 3 to 4 years to develop the technology of newborn hearing screening. And in the USA, the newborn hearing screening became universal in 1998, in UK in 2003, and in Cochin, we made the attempt in 2003, almost the same time as UK. So in US and UK, it was universal, but we just started in Cochin in 2003. So this is a screening program initiated in January 2003. And you can see the collector, Ganesh Kumar, you can see here. And now he is the Chief Election Commissioner in Delhi now. And actually the simulation which I got was, I was asked to go for a talk by Dr. T.U. Sukumaran in 2002 in Kottayam. And the topic was early identification of hearing loss in children. So when I came back, I had an idea, why don't we start the program in India? Because there was nowhere in India it was being done that time. So I put forward this in the IAP coaching group, and nobody was very enthusiastic because nobody was doing it. And they not very enthusiastic response on the Cochin. This one. Then I met Ganesh Kumar. So he said, you go ahead. I fund 50% of the money. Luckily, we had an ENT conference at that time, and we procured the machine which was costing 1.8 lakhs, and collector promptly gave us 50%. And the 50% rest, 50% we got from IAP Cochin. And we procured the machine, and procure the machine, it was very difficult because there was no practical training. And even in USA, UK also, there was no literature at that time on newborn hearing. So I wrote to my friend in USA, Dr. Thomas Stephen. So he sent by courier some literature from there. And by that we had the machine. And we had only 20 deliveries in Cochin Hospital, and we screened all the babies for 2-3 months. All the babies were normal. We sent the babies to different hospitals. All of them promptly refused. They said, no, all the babies in our hospital are normal. So luckily, Dr. Tony helped us, and saw the Lakshmi Hospital, Dr. Maria, and we started the program. And luckily, we got a baby who was positive, who had a problem with the hearing, and we propagated this through the print and electronic media, and there was a gradual increasing response at that time. And this is the small machine weighing just 150 grams for OAE screening. And this is the procedure. We put the probe into the baby's ear and put the click, and the machine produces the click sounds that goes from the external ear to the mid ear to the inner ear to the cochlea. And this causes the movement of the fluid in the cochlea. That will cause the outer hair cells of the cochlea to move. When the outer hair cells move, that produces sound. And this sound wave is picked up by the tiny machine, and you get a tick mark in the machine. So the procedure takes just about 1 to 2 minutes, and you get the recording. The first screening actually we've done before discharge from the hospital, but it is better to do the screening, OIA screening, on the day of discharge, because if you do it on day 1, it's very likely that we get a high number of false positives because of the serum in the external ear or some fluid in the middle ear. So it is preferably done on the day of discharge by 72 hours or after 48 hours. And if you get an abnormal report, if you repeat again at 4 weeks or at the first immunization visit for convenience, and if that again is abnormal, we do a BARA test. And the 2-stage screening is 99 specific. But this is for the general babies, and all the babies in NICU should undergo ABR because there's a high incidence of auditory neuropathy and auditory dyssynchrony, which occurs in the NICU babies. So all the NICU babies should have the ABR testing done, whereas in the other babies, the well babies, we can do this OAE as the first step and BARA as a second step. And all babies abnormal ABR undergo detailed evaluation, hearing aid fitting, and auditory visual therapy before 6 months of age. And our goal is screening before 1 month, diagnosis before 3 months of age, and intervention before 6 months of age, as per American Academy of Pediatrics. Now, actually, we are moving to 1, 2, 3. That is screening by 1 month, diagnosis by 2 months, and intervention by 3 months. So we get excellent results with this. And this is our small team. And in 2003, we had 1 machine, 2 hospitals, and 1 screener. And by 2007, there was more response. We had 5 machines. We screened all the 38 hospitals in the city of Cochin with the 5 screeners. And in 2013, when we had the 10th anniversary of newborn hearing screening, then district collector Rajamanikya asked us, why don't you do it for the entire district? We took up the challenge. There were 91 hospitals in the district, and we procured 2 more machines and 2 more screeners. And in 2014, we covered the entire district of Ernakulam, that is 91 hospitals. And 13 hospitals had their own in-house facility. We were covering 78 hospitals with 7 screeners and a coordinator. And now IAP Cochin is screening for 50 private hospitals in the district of Ernakulam. And one difference I want to comment regarding our screening program is that, and compared to what they do in USA or UK, is that in USA or UK, they give a counseling for about 1 hour to the parents, how the test is being done, and the complications and all those things they explain. And they take about 1 to 1.5 hours to screen 1 baby. Here, actually, we were also taking the consent from the parents. And what happened was, when you take the consent, the first parent will say, no, we don't want it. So everybody will say, no, we don't want it. So then we decided that we won't take any consent. We will do it for all the babies in the ward. And if they don't have money, no problem. And we don't charge anything. But we see to it that all the babies are screened before they leave the hospital. And here within 1 hour, we screen about 30 babies. In USA, with 1 hour, they screen a baby. So that is the main difference between the screening in India and in the rest of the world. And now from January 2003 to February 2025, we have screened 3,22,331 babies. And out of that, 2,50,000 were in the well baby group, and 72,252 were in the high risk group. And out of the 72,252 high risk babies, we got 941 babies had a abnormal BARA. And out of the so-called well babies, 134 had a abnormal BARA. So around 1,050 babies we could detect at birth, and these babies are on remediation now, and most of them are doing extremely well. And if you do the remediation before 6 months of age, as I said earlier, by the mild, moderate, and severe babies, they will require only a hearing aid costing about 35,000 rupees. And whereas if you miss that period, or if you even a profound hearing loss, they may require a cochlear implant. Actually, the program of Sruti Tarangam was started when Sri late Umanjandi was chief minister, and the cochlear implant program was there in 2014, and they had a meeting in Le Méridien after they completed 500 cochlear implants. And I just went to Le Méridien, and after the meeting, I got just a minute to talk to him. And I said, sir, this cochlear implant program is very good, but actually what we should be doing is we should screen the babies at birth, so that is what is being done in the rest of the world. And it takes only 1 minute, and the equipment costs only about 2 lakhs rupees. The cochlear implant will cost about 6 to 7 lakhs rupees. So in that crowd of about 100 people around him, he took it up. And in 2014, he saw to it that all the hospitals in Kerala had the screening program done. So that is, Kerala became the first state in India to have a screening program in all the hospital, the delivery points. And what you have found here is that the highest incidence of hearing loss was in families with their family history and hyperbilirubinemia, and other risk factors are birth weight less than 1,200 grams preterms, and these came second. The family history of hearing loss and jaundice were the highest risk factors in our series. And this is the first baby, Dilna. This baby at 5 months had a hearing aid fitted. He had bilateral moderately severe hearing loss, jaundice, and hearing aid. This is the first baby who actually saved our program in Cochin, and this is the first baby who had a hearing aid fitted at the 5 months of age. And this is Dilna again at the 10 years. She was attending a normal school, and she had a normal speech and hearing language. This is the first baby we could detect in 2003 January. So these are the babies who had a hearing aid fitted before 6 months of age. And we had put this in this hearing aid screening program, and the workshops were done almost all the pediatric national conferences from 2003 onwards. And in the Asia Pacific Conference in New Delhi, September 13, and again the National Conference in Melbourne. And I was this WHO meeting with the representatives of Southeast Asia countries, and I was elected the lead expert to implement this centralized newborn hearing screening program in the Southeast Asia countries. And actually, what is the difference between the screening program in Cochin or Kerala and other states is that what we emphasize is that with one machine, you can cover at least 4 to 5 hospitals nearby, because OSCE hospital did not have to invest on an equipment. So when the hospitals can invest 1 or 2 crores of rupees in NICU, they can invest about 3 lakhs rupees for a hearing screening machine. And with this one, it's a portable one. So you can screen 5 to 6 hospitals. So that is what we called the centralized newborn hearing screening program. And the Cochin model was international. And we had many international conferences where it was being presented. And the government of Kerala, as I said earlier, initiated the newborn hearing screening in 2014. And our task was to screen, this is the Hearing Friendly Kerala, the project in 2020, when Dr. Narayan was the state president. So our task was to screen 13 districts advocacy, planning, and coordination. And we made sure that the in-house facility is there and centralized screening was promoted. And Ernakulam district were declared in 2014. Subsequently, Kollam, all the other districts were declared hearing friendly. And in 2020, December 20th, 2020, Kerala was declared hearing friendly by the then Health Minister, Shelja Teacher. And this is a dream come to me for me. This is David Kemp, who came to Trivandrum in 2015. And I had a great opportunity to touch this great personality. And it was a dream come true for me to meet and touch this great personality. Actually, he was quite impressed with the program in Cochin, which was being done. And he was very happy to share his experiences. And one of these infants has a hearing loss, and only newborn hearing screening can help you determine which one, because all the babies look alike. Only by screening you can see which baby got a hearing problem. Thank you.
Thank you, sir, for that excellent speech. Topic is open for discussion. So someone has asked in the chat box, how do we select the correct hearing aid with correct pitch and decibels in a young baby?
Hearing aid, actually, we are not entering into that field, because what we do is, because we cover almost 50 hospitals now, and even Jubilee Hospital at Trichur we are covering. So one of our staff goes there 5 days a week to Jubilee. She goes in the morning and come back in the evening. So what we do is we do the screening. If it's abnormal, again we repeat. We give a date, and if it is again abnormal, we advise them bear a test, and we entrust the pediatrician to follow up the case, because it is difficult for us to follow up. So once we detect it, actually sometimes we send them to NIST Trivandrum or to a nearby place. They only do the hearing aid fitting and subsequent follow-up.
Sir, we were coming to Thrissur in 2013 also frequently. Dr. Parvati invited.
Yeah, sure. Still we are coming. Now we are coming to Jubilee only. And other hospitals, I think they got private players. Now, anyway, it is being done. That's a good thing that the private players also a key part, so that Kerala is much ahead of other states in India.
We all remember sir, somebody coming from your center, sir, to GMC Thrissur when we were junior pediatricians there, because that was our first experience with newborn hearing screening. Are there any other queries?
Abraham sir, Dr. Santosh here.
Yeah, tell me, sir.
We hear, sir, in every meeting, but every time there is something fresh to learn from you, even though it is the same topic we are hearing. So wonderful presentation, a wonderful evening. Just one comment only, it is for everybody else also. Nowadays, we are seeing a lot of autistic children, and the incidence is on the rise. We don't know whether it is because of increased detection or otherwise, but nowadays we see that, I think my opinion and the expert opinion is, whenever we see a speech delay, we should first rule out the hearing defect. Many a time we see that even pediatricians are diagnosing it as autism and then referring. In fact, some of them might be having a hearing issue also. So my message is that if there is a speech delay, the first thing to look for is hearing, and then only we should consider other. Even if there are other symptoms of development disorders like autism, we should still have a hearing screening. And I make it a point that any child I see with a speech delay, we'll always screen for hearing problem. Just a comment, sir. Thank you.
Yeah. See, other thing what I want to emphasize is that whenever a child comes to us, I think on a routine visit, if a child comes at 1 or 1.5 years, you should make it a practice to ask the mother whether the child speaks or not. Because these parents mostly are interested in the weight only. They want to, the main complaint, the child does not eat. That is the most common complaint. So I think you should tell them that the brain development is more important than the body becoming fat or obese. So I think you should ask them whether the child, because out of all the developmental milestones, I think the most important again is a hearing or the language development compared to motor development. So actually language development actually is proportionate to the intelligence IQ. So I think we should make a stress that we should ask them whether the child speaks or not, and whether there's a delay in this one. And there's a practice among some pediatrics at least that no, we can wait for somebody. And that should never come from the mouth of a pediatrician. If a child does not speak, you tell them you have the hearing test done first. Then only you can reassure them that the child will speak. And other thing is that the excess use of mobiles and gadgets. So even we say that when the baby is in the maternity ward also, you can see the mobile just kept near the baby. And now that trend that when the baby comes at one month or 2 months, the baby cries, they immediately show the mobile to the child. So I think that practice should be discouraged. And actually, the American pediatrics below 2 years of age, no screen time at all. From 1 to 2 years, 1 hour is allowed. After 5 years, 2 hours. So that's the screen time allowed by the American pediatrics. I think we should make sure that this habit of mobile access screen time should be discouraged, and we should make it a point that we make the parents aware of the bad effects of the excess screen time.
Sir, there is a query in the chat box. Will it be enough to do high-risk screening or need to do it in all newborns?
Which one?
Will it be enough to do high-risk screening or need to do
No.
all newborns?
No.
That's a
As
query
you
in
have
the
seen
chat
in the
box.
chart, the hearing loss occurs in the belly babies also. So high risk screening, the incidence is 1%, whereas in the normal population, 1 in 1,000. But if you do it, we will maybe it's about 25 to 30% of babies if you do only high risk screening. The high risk babies should have a bearer test done, whereas other babies, the so-called well baby nursery babies, they can have a OAE as the first test and subsequently bearer if the 2 OAEs are abnormal.
Are there any more queries? Thank you, sir. Thank you so much for that wonderful talk. Shall we move to the next session? Dr. Megha, are you ready to share your screen? Dr. Megha?
Hi.
Shall we go straight to the
Good evening. Yeah. I'll just
Are the
share.
PGs ready? Dr. Shifa, Dr. Finsi, Dr. Hannah, Sangeeta, Veena, Akhila. Are the PGs? Okay, I think they are in the group. So, madam, you can call one of them and others can write in the chat box. I will check the chat box and let you know the reply. Okay. Can you share the screen?
It's shared. You can see that?
Not yet.
Just a second.
That's a start sharing the screen option is there in the bottom.
Yeah.
There's a share option, no? In the
just a second.
Bottom panel.
10 minutes.
Have you kept the PowerPoint open, madam?
Yeah, it's open.
So, share screen option is there.
I have actually clicked it, but yeah, just a second. I think I will have to go to window, then only it will come. Yeah, correct. Yes, it will come now. You can see now?
Yes.
Oh,
Now
sorry,
it is visible.
sorry, just
but it has gone. Now it is not visible. Madam, can you do it once again?
Yeah, I'm doing. You can see now?
Yes. Can you put it in the slideshow mode.
Okay, see.
Yes, it's not in the slideshow mode.
Slideshow only. No.
No, no.
No.
Not in the slideshow mode, but it is visible.
I put the slideshow mode only. Not coming.
Not. It's not in the slideshow mode, but still it is visible.
Is it okay to?
Yes, I think we can proceed.
Okay. Yeah. So a warm good evening to all. I'm actually new in IAP. First of all, I would like to thank Dr. Vivin and Dr. Latika for giving me an opportunity to be part of this teaching program. So after the wonderful and interesting class by Abraham sir, so we'll go to few OSCE questions related to pediatric ENT. Can we start?
Yes, yes, ma'am.
Okay. So you can see the screen, right? So this is a 2-year-old child with speech delay and not responding to sounds, and he came for
Question hasn't
evaluation.
come, ma'am. Excuse me, ma'am.
Sorry.
This slide is not moving. Can you show the next slide? It's still showing OSCE in pediatric. Yes, now it is come.
It's coming. Just a second.
Yes. Now it is visible. Question 1 is visible.
Now, is it like in a slideshow or?
No, it's not in slideshow mode.
Can you make a slideshow?
It's actually I've made it slideshow, but I don't know why it's not coming.
You stop sharing and again restart.
Okay, just a second. I think. Now?
It's not in the slideshow mode. Can you again press the slideshow button?
No, I think even after making a slideshow, it's not. It's coming as slideshow for me, but I don't think it's coming there, right?
Yes, ma'am.
So I'll do one thing. I'll just zoom it. Is it better? Like,
Somebody has written we should share entire screen. Joe, sir.
entire screen. Just a second.
Or someone has written press F5 on the keyboard. F5.
XY.
F5. F5. F5.
F5.
S.
Function.
Okay. I don't think it is. Once more I try. Is it coming now?
Screen is not visible, madam.
Not coming.
So in that case, you can start screen sharing, madam.
Yeah, we'll start that way.
Yes. Now it's okay, madam. Okay, madam.
Okay.
Madam, you're muted. Madam, you're muted, madam. Madam, in the bottom panel, there's a picture of that mic. Joe, sir.
Now
Yes.
I'm
Now
right.
you're audible. Can you
But the
start
screen has
sharing
gone.
the screen?
Understood, but there is some issue, I think. So I know now the it's not the full screen, right?
No, it's not the full screen.
Basically, when I actually when I make it a full screen, the audio is going actually. So
See,
is
madam,
it
you can
okay?
start this way. Okay, that's okay.
It's visible.
Yes, it's visible.
Okay. So the first question is: we have a 2-year. This is a 2-year-old child with speech delay, who was not responding to loud sounds, and he came for evaluation, and he underwent the below test. This is the test the child is undergoing, and this is the test result. So, what is the test, and what is the finding, and as a part of further management, what will be the next investigation and the treatment
Madam,
option?
can you put the first question? Previous slide. Previous slide.
This is the first slide.
This is the first slide.
Huh.
Question number 1.
This is the first question number 1. Is it seen?
Okay.
It's seen, no?
Yeah, I think we are seeing the answers.
Oh, sorry. Anyway, we'll continue. Now
Yes,
the question is seen, right?
No. We are seeing only the next slide, answer slide.
What are you seeing now?
Same slide only, madam.
Okay, then I don't know why it is.
Now it's in OSCE
Okay, now we'll go
pediatric
slide by
ENT.
slide. Then okay. Yeah, I understood. Yeah. Okay, this is the first slide. This is you're seeing, right? The question.
Yes.
Okay. So, question: the 2-year-old child came with speech delay and not responding to sounds, and as a part of evaluation, he's undergoing the test. This is the test result. So, the first question is: what is the test, and what is a finding? And so we'll call one of the PGs, maybe Dr. Hannah. Dr. Hannah is there?
Dr. Hannah? Dr. Hannah, are you there?
Hello?
Yes, you can answer.
So can you just identify the test? With the electrodes. This is the ground electrode.
Dr.
Hello?
Hannah? Dr. Hannah? Can you answer?
Yeah, can you hear me?
Yes,
Yeah,
yes.
I have
Yeah,
already
you're
seen the answer.
Can you answer?
It's better. Brains.
So the child has got a ground
Hello?
electrode. Then the
Hello?
other electrodes are there. The child is sedated. Hello.
Can you hear me? It's better.
Yes.
Okay. Yeah. Good. So the first answer is this is the Bera test. And now maybe Dr. Fincy, can you say the finding of the Bera, the result? So both ears were tested. This is the left ear and this is the right ear. Dr. Fincy is there?
Yes, madam. Yes.
Okay.
I don't know, madam.
Can you be a little more louder, Dr. Fincy? You're not audible.
Can you be a little more louder? Yeah, I mean.
Fincy, you're not audible.
I don't know the answer, madam.
Okay. So, okay. So then, suppose okay. We'll go to maybe Dr. Veena. Or anybody can answer, no issues.
Dr. Shifa, Dr. Akhila, someone can answer?
The child is not speaking.
The typical waveforms are not seen. Madam?
Okay, yeah, I can hear. Yeah, correct. That is correct actually. The waveforms are seen, which is actually suggestive of hearing loss. It's like there are no waveforms, which means the child is having profound hearing loss. And as a part of, now we know that the child is having profound hearing loss, and what will be the, as a part of further management, what will be the investigation? This is basically for the management, which is going to be the surgical management. So what investigation is needed for the child? Because now we know the child is having the profound hearing loss. We need to see the nerves.
CT or MRI. Have to do the imaging.
Correct. Very good. So we will need the imaging that includes both CT, temporal bone, and MRI. And this is a case of bilateral profound hearing loss. So what will be the treatment option? Maybe Dr. Sankita is there, huh?
Yes, ma'am.
So what will be the treatment option?
Hearing implant, cochlear implant.
Yeah, cochlear implant, exactly. So the this actually needs cochlear implantation. So when we coming to the answers, this is like, and this is the test is BERA, brainstem evoked response audiometry. It's also known as ABR. So this is the normal BERA waveforms. You all know. This is the diagrammatic representation. This is how you get actually when we do. So there will be 7 waves, and when we do the testing, if there is no hearing, we won't get any waveforms. And the particular one is the important one is the 5th wave, because it is the highest wave and it is a consistent wave. So that actually will be seen, that actually will be very prominent. So that is detected first. Okay, so the previous slide, this you can see there are no waveforms at all because there is no peak, all are flat. So that means there is bilateral profound hearing loss. There is no response to any threshold. And the next investigation will be imaging, which will be the MRI and the CT temporal bone. The treatment option definitely is cochlear implantation, and this is just a picture of the cochlear implantation where the outer hair cells of the cochlea is damaged, and we are putting an electrode from outside through surgery, which is actually helping the child to hear. So this is a cochlear electrodes. Clear?
Yes, ma'am.
Okay. So shall we go to the next question?
Yes, ma'am.
So this question definitely will be answered because of the because of Abraham's talk. Definitely the answer should come. So the second question, this is identify the test or the equipment. Okay, who is there? Maybe Akhila, Dr. Akhila.
Yes, ma'am.
Yeah, tell me.
The test would be autoacoustic emission, OA.
It's slightly different. I mean, it is basically used for neonatal hearing test, but it is not actually OA. Okay, we'll come to that. So tell me the options for neonatal screening testing.
Autoacoustic emission.
Okay,
That
and
means BERA.
Autoacoustic emission and?
That fails ABR, auditory brainstem.
So basically, okay, we'll come to that. Now tell me what is the rule of 136?
That is screening within 1 month, diagnosis within 3 months, and intervention should be done within 6 months of age.
Okay, very good. Now, so what will you do if the abort test is, comes as rougher?
We have to repeat it at the 6th week or the first immunization day, or the first immunization. We have to repeat.
Okay.
Oh,
okay, and then also if it fails, if it is rougher,
then ABR we have to do. ABR
we have to do the BERA. Okay, so this is again, this is actually not OAE. This is BERAphone. This is also, so there are two options for neonatal hearing screening. One is the OAE, autoacoustic emission, which is the commonly used one. But the second one is a BERAphone. So this is a equipment. BERAphone is basically automated ABR. It's not the proper ABR. It is automated ABR. So the difference is that this will actually detect any hearing loss above 40 decibel. So this also can be used as hearing screening. So when comparing OAE and ABR, that is BERAphone, the advantage is that OAE may miss auditory neuropathy, but BERAphone, the auditory neuropathy will not be missed, because OAE pass means the outer hair cell, the cochlear hair cells are working, but the auditory neuropathy may be missed because that is actually the problem at the junction, synaptic junction between the hair cell and the nerve. But BERAphone, the auditory neuropathy will not be missed. So these are the two options for neonatal hearing screening. Then again, a rule of 136, as you said, you know, but as Abraham has said, now actually it is coming like little earlier, like it's becoming 1, 2, 3 instead of 136. But universally it's followed like 136. Now, shall we go to the next question? Okay, so this is slightly different from hearing. Now, here we have am I audible?
Yes, ma'am.
Hello?
Yes, ma'am, you're audible.
Okay. So this is a 2-day-old neonate in NICU on persistent respiratory support. Nasogastric tube could not be passed on through the both nostrils. So this is the infant. what is the diagnosis and what are the differential diagnosis and what is the immediate measure, I mean the supportive measures which is taken here, which is shown in the picture. Dr. Hannah, you are there?
Yes, ma'am.
Okay. Can you tell me what is the probable diagnosis?
Choanal
Choanal atresia, correct. So this is mostly bilateral choanal atresia, we can say. And what are the differential diagnosis?
Can be septal deviation also.
Okay. Then? Anything else?
Stenosis.
Yeah, where?
Nasal stenosis.
Okay, mid-nasal stenosis we say. Then one more thing is there. Have you heard of piriform upper chest stenosis?
No.
Okay, that is also part of this. Now, coming to the immediate measures, what is actually the child, what supportive measure has been given to the child? What
Maintaining oral airway.
There is a particular name for that device actually. And there is something which can actually help in the immediate, so that the child can actually breathe through the mouth. Because basically newborns are obligate nasal breathers. They don't know how to breathe through the mouth. So this will help them to breathe through the mouth. That is the idea. Anybody else? Maybe Shifa, Dr. Shifa is there?
Yes, madam. Oropharyngeal airway?
No, it's a special type of nipple actually. Dr. Fincy, Dr. Sangeeta, Dr. Veena,
Ma'am, long-teated nipple.
Sorry?
Long-teated nipple.
Basically, a nipple with wide open mouth. It's called McGovern's nipple. Okay, so these are the answers. So the probable diagnosis definitely choanal atresia because the NG tube cannot be passed through both the nostrils. So this is the imaging CT scan of the child showing choanal atresia, where choanal atresia is basically the persistence of bucco-nasal membrane. It's usually in 1 in 5,000 to 8,000. It's more in female, and unilateral is more common than bilateral. Bilateral is usually rare. But you can here see that the CT scan is showing the bilateral choanal atresia picture. Then the similar picture we can get in 3 conditions. That is, one is the choanal atresia, second one is the congenital piriform upper chest stenosis, and third one is the mid-nasal stenosis. These are the CT scan of the above conditions. Now, this is the important thing. This is actually, you can see the McGovern's nipple. So this is a nipple, normal nipple, where here actually the mouth will be opened wide, and the child is actually it is kept in child's mouth so that child will actually breathe through the mouth. Because they are obligate nasal breathers, they don't know how to breathe through the mouth, but using McGovern's nipple make them breathe through the mouth. That is the idea. Okay, shall we go to the next question?
Yes, ma'am.
Yeah. Now we will move to airway. Okay. So this is a 6-month-old baby presented with noisy breathing, which is worsened while feeding and crying. But the noisy breathing was better when the child was in prone position. You can actually see the video of the child. The video is seen?
Yes, yes.
Video is seen?
Yes, it was visible.
Okay, okay. Okay. So on examination, the child was having biphasic stridor with suprasternal retractions, and we did a fiber optic flexible laryngoscopy. and that was showing. I'll just show you the video. This is the laryngoscopic video of the child. You can see the epiglottis. You can barely see the vocal cords. So, what is the probable diagnosis? And what is the classification? Then management. Okay, now maybe Dr. Veena.
Ma'am, congenital laryngomalacia.
Okay. Have you heard of any classification of laryngomalacia?
No, ma'am.
Okay, that's a little on the tougher side. Management options, what will we do?
Can wait for 1 year. If still persisting, may go for surgical options.
Okay, so during that 1 year, what all things will you monitor? What will we tell the parents?
Maybe we can do some anti-GERD measures.
Okay, good.
Then feeding practices can be modified.
Okay. Yeah, that's it. And monitoring of the weight. Now, surgical options, have you heard of anything? Any name of the surgeries you know? I know it's not coming to your area, but still. Anyone?
Someone has answered in the chat box supraglotoplasty.
Okay, yeah, correct. Supraglotoplasty. Okay, now we'll go to the answers. Very good. So that is classical laryngomalacia. I mean, the first diagnosis is definitely classic laryngomalacia because it's the most common congenital airway anomaly in children. The classification is, I know you may not be familiar with it, but the classification is Hollinger classification. That is basically modified Hollinger classification. There are 3 types, type 1, type 2 and type 3. So this is based on the structure. So this is actually the epiglottis. This is the arytenoids. And in type 1, it is actually the inward collapse of the aryepiglottifold. That may be difficult to appreciate in this. And type 2, that is this one, will be the curled epiglottis you can see. And the aryepiglottifold, that is on both sides, will be really short. And type 3 will be, this is the epiglottis. You can see here and all, epiglottis is anterior. This is anterior, this is posterior. But here in type 3, the epiglottis is coming posteriorly over the arytenoids, which means the severity is definitely more. So there is a modified Hollinger classification. Then, yeah, again, conservative measures, definitely it's for conservative measures, weight monitoring, feeding upright position, anti-reflex measures, modifying the feeding techniques. Surgical management is supraglottoplasty and epiglottopexy, which, I mean, you don't need to know the details. The surgical indications are failure to thrive, cyanotic or apneic episodes, and persistent SpO2 less than 95%. Okay, now we will go to the next question. Okay, this is actually the easiest one. So this is a 6-year-old child presented with history of recurrent upper respiratory tract infection, for which he was treated with antibiotics, and his speech was actually not clear. There was some misarticulation, and the parents noticed that the child is actually keeping the TV volume very high. And this is the otoscopy finding. This is the right ear, this is the left ear. Otoscopic finding of the child. And he had a audiometric testing. This is the pure tone audiometry of the child. And there's a tympanogram also. Now, who is going to answer? Okay, Dr. Fincy, can you tell me the audiogram finding? Dr. Fincy?
Yes, madam.
You're there?
Yes, madam.
You're not audible. Can you be a little more louder?
Yes, madam.
Okay, yeah. Okay, tell me either the ear finding, otoscopy finding, or the pure tone audiometry finding. Anyone?
Tympanic membrane showing the bulging of tympanic membrane.
Okay.
And redness and bulge. AU.
Okay.
Having audiogram showing hearing loss.
Can you be more specific? What type of hearing loss?
Conductive hearing loss.
How do you know? Okay, no problem. Conductive hearing loss, because you can actually see the airborne gap.
Yeah.
Now tell me the diagnosis. A child is having lusterless dull tympanic membrane, which is bulging, which means fluid is there inside, and the audiogram of the child is having bilateral conductive hearing loss. Fincy only, no?
Yes. Otitis media with acute suppurative otitis media. Suppurative otitis media.
So suppurative otitis media means there will be acute infection. The child actually presented with history of recurrent infection, but now the child is not having any features of acute infection. He presented with the speech clarity issues and hearing loss, basically.
Two answers are there in the chat box. One is serous otitis media, another one is otitis media with effusion.
Okay, so both are same only. So that is the answer. That is serous otitis media or otitis media with effusion. Audiogram finding is again conductive hearing loss. So, yeah. Okay. The next question for the same OSCE is, what is the nasal pathology that you will suspect in this child? Maybe Sangeeta can answer. Dr. Sangeeta?
Deviate nasal septum.
Can you be a little more louder?
Deviate nasal septum.
This is a 6-year-old child, and the child is having recurrent respiratory tract infection and bilateral symmetrical hearing loss is there.
Sinusitis.
We cannot say that it is not deviated nasal septum, but to be more specific,
sinusitis.
Sinusitis cannot actually cause hearing loss unless it is, persistent.
Someone has written polyp as answer.
Okay. So maybe because I said it as nose, I meant it as nasopharynx. So okay, we'll go to the answers.
Anna has written adenoids.
Okay, yeah, that's what the answer I wanted actually. So we'll go to the discussion part. So this is the dull lusterless tympanic membrane, definitely bulging with middle ear fluid. So usually the tympanic membrane will be translucent. This is dull lusterless, which means there is fluid inside. And the diagnosis is by seeing the tympanic membrane itself, it is serous otitis media. And this is the tympanogram of the child. It is flat. So the flat type tympanogram is B type, which means there is fluid inside. And this is a hearing, pure tone audiometry. I think you know the basic pure tone audiometric findings. So left is always conventionally usually every hearing test, it is the left will be blue and the red color will be right. So here you can see actually the airborne gap, which indicates the pure tone, conductive hearing loss. And this is the endoscopy picture of the child, which is showing the adenoid hypertrophy. You can see that this is one of the cornea, seeing the nasopharynx, there is adenoid hypertrophy. And okay, I didn't ask this question. What is a treatment option for the child? Dr. Akhila? Dr. Aguila is there? Am I audible?
Yes, ma'am.
Okay. Dr. Aguila is there?
Akila?
Or maybe Dr. Shifa?
For acute serious otitis,
Or anybody?
Shifa can answer.
for serious otitis media, we can do grommet insertion.
Okay. So,
For adenoids, we can use nasal sprays, nasal sprays. And if after 7 years, we can do adenoidectomy.
why are you waiting till 7 years?
Or if it is interfering with the well-being of child, we can do it early.
Interfering with the
well-being of the child, we can do it early.
Okay. So, ideally, any time after 2 years, based on the symptoms, not responding to medication, we can actually go for adenoidectomy after 2 years. Ideally, after 3 years, but 2 to 3 years, depending on whether there are OSCE symptoms or not. So here, the first treatment option definitely will be conservative management, which will be the topical steroids, topical nasal sprays. And we can give for 3 months and see the response, see the audiometric finding. And if still persistent ear fluid and leading to conductive hearing loss, we can go for adenoidectomy with laryngotomy, that is opening of the tympanic membrane, and put the grommet inside. Okay. Now, yeah, maybe I think this is my last question. Yeah. So this is a 7-year-old boy with history of recurrent wheeze and lower respiratory tract infection. But the mother remembers history of choking episode while the child was playing. This is a chest X-ray of the child. What is the probable diagnosis? Hannah can answer. Dr. Hannah?
Hannah can answer.
Yes, ma'am.
Hannah?
Yes, ma'am.
Can you answer?
Yes, ma'am.
So that history of choking episodes is there. Okay.
Foreign body aspiration.
Yeah, in a child with recurrent LRTI with history of choking episode, the first diagnosis definitely is foreign body aspiration. What is the chest X-ray finding?
There is hyperlucency over the left.
Yeah, correct.
Left
So,
lung.
correct. So, what is the treatment? What is the next procedure to do? What is the next step?
Bronchoscopy and removal of the foreign body.
Correct. Very good. So, basically, it's a suspected foreign body aspiration, hyperinflation of the left lung, and you know that ball valve mechanism where during where the foreign body is trapped, and during inspiration air will be trapped inside, and expiration air won't be able to go out. And the treatment is bronchoscopy, diagnostic bronchoscopy, followed by removal of the foreign body. Okay, so now we'll just see just few syndromes. Okay, syndromes related to hearing loss. So I just want you to tell the just name of the syndrome. See, the child has got a cochlear implant. This is a cochlear implant, and definitely the answer should come because it was shown in Abraham sir's slide. So definitely the answer should come.
Okay, answers are come in the chat box. Waardenburg syndrome.
Very good. Okay. So this is Waardenburg syndrome because you can actually see the white forelock, pigmentation of the iris, and the cochlear implant, which means the child has got hearing loss and the pigmentation issues. So this is one of the syndromes associated with hearing loss. Okay, the next one. This is again, I'm telling only the syndromes associated with hearing loss, because you can see the child has a hearing aid, and this is the picture is that of a retina. This also was shown in Abraham's slide. Hannah, Fincy, Veena, Sangeeta, Shifa or Akila? Anybody?
Usher syndrome.
Okay. Sorry? Okay, very good, very good. Again, actually, this is hearing loss and retinitis pigmentosa. So the syndrome associated is Usher syndrome. There are 3 types, type 1 to 3. And type 1 usually will have profound hearing loss, which will need cochlear implantation. The type 3 will be usually normal hearing, and type 2 in between, moderate SNH. Next one is, okay. You can see, again, the child is having a hearing aid, and the child is having a neck swelling.
Answers have come in the chat box, Pendred syndrome.
Okay, very good. So it's Pendred syndrome. Basically, the associations are sensory neural hearing loss and the euthyroid goiter. The child will have goiter, but the child will be euthyroid. It is because of the mutation of the pendrin gene. Okay. Now the last quarter. Again, you can see the child has got a hearing aid. This arrow is actually a branchial sinus. The child has got a preauricular sinus also. Answers, please. Anyone? This
Can
is
anyone
last
answer? Someone has, Dr. Akhila has answered brachio-otorenal syndrome.
Very good, very good. Dr. Akhila is there, no? She can answer, right? Not in the chat box. Okay, so this is brachio-otorenal spectrum disorder, which is also known as BORSD, BOSD. It's an autosomal dominant one. It is associated with inner ear, middle ear, and outer ear anomalies, brachial fistula, and sinus, and usually associated with renal anomalies also. Okay, so those are the spotters, and thank you everyone. Basically, I would like to, as a like part of World Hearing Day, I would just like to tell everybody that we have actually, Lisi Hospital has did a soft launching of cochlear implantation program, that is LIS Ravan. As a part of World Hearing Day, we have actually planned for free cochlear implantation for the selected kids. So just informing all of you. So
Thank you, madam. Thank you, madam, for that very good presentation and asking questions. I'm sure that students have gained so much from this session. Are there any queries to madam?
Thank you, Megha. A useful learning session. Megha, about that coin literacy part, you mentioned about 3 reasons. Is there a possibility of an encephalocele coming out through the nose? I have seen through the nose, but always it will be visible. So is there a possibility of not coming out, but actually causing a DD for this stenosis?
Encephalocele actually can come through the nose, sir, but usually it will be from the skull base. So, which means it will be anterior to the choana. So usually, unless it is fully blocking the nose, I mean, it is too big, blocking the entire nose, the NG tube passage won't be that difficult. Because the choana will be free, and the anterior to the choana, there is a skull base. So usually it comes from the skull base. But if it is really big and blocking both the nasal cavities, it can be a DD, sir.
Unrelated to this thing, I have a baby now in the 8-year-old kid now in the ICU. We had a trap. It's an accident following CS, which CSF rhinorrhea was there. That was corrected. She was symptomatic for the last few years with some sequelae in the speech and all. But now she's having again fever, and mother said there was a dripping from one nostril, and that disappeared. So what is the chance of this thing reappearing, or the failure of this correction of this?
The child underwent surgery for the CSF.
The surgery and correction. Those are asymptomatic for the last 1 year. Now again, this rhinorrhea.
Okay. So normally the CSF rhinorrhea closure after surgery, the chance of recurrence basically depends on how the surgery was done and what was the primary pathology. Like suppose the primary pathology was something which actually causes an increase in intracranial pressure. That case, the failure rate is very high, maybe more than 30%. But if it is normal pressure, like trauma, it should not be a high pressure leak. It should be a normal pressure leak or low pressure leak. So usually in that cases, the chance of leak is usually very less. I mean, maybe less than 3%. But usually high pressure leak, the chance of recurrence is high. And depends on the surgery, because there are different types. Like you can actually have the double layer closure or single layer closure, depending on the place where the surgical surgery is done.
Thank you.
Okay, sir.
Okay. So, Shingaravelu sir is there. Sir is an examiner for both DNB and MD. Sir wants to add something. I don't know, sir.
That was there in the beginning.
Yes. I think it was a very useful session because this ENT is a little difficult for us because all these pictures and everything you have explained very well. I think students may have benefited very much. And I also wish we should revisit these videos because the new things, I usually do it because sometimes if you revisit it only, we will understand.
Yes, oh yeah.
Okay, sir.
Send it fully diagram.
Thank you, Megha.
Thank you, sir. Thank you so much for giving me an opportunity here to be part of actually this teaching program, sir.
There is a query in the chat box. How early can we do cochlear implant in a child?
So the earliest age for a cochlear implantation, I mean, as already Abraham sir has said, that the earliest intervention, that is the key. Early intervention is a key. So the cochlear implantation can be done as early as, like any age, I mean any time after 6 months. So basically 6 months is a time for the skull to develop completely. So we give time till 6 months, and after 6 months, any time that can be done.
Shanavas sir is there in the Shanavas sir, anything you want to add? Notes. Okay. If there are no more questions, thanks once again. And we will meet again next week with another topic and another speaker. Thank you.
Thank you, sir. Thank
you all.
Thank
Good
you,
night.
Latika, for coordinating so nicely.
Thank you, Riaz. Thank you, everyone.
Thank you, sir.